I invite Dr. Anup, sir, for enlightening regarding the phacoemulsification in shallow AC. What all things we should look for. He's a senior phaco surgeon at the I Vision Hospital, Thrissur. He will be enlightening us regarding the same.
Very good afternoon. So I'll be talking on phacoemulsification shallow anterior chamber, and I'd like to thank Jane for having me in the team. Things to ponder. Actually, many times in this situation, there is hardly any time to ponder. You have to really go in and do some fast thinking. So pre-operative challenges, of course, many of these patients have small eyes. So IL power calculation is itself a challenge. So you cannot use the normal SRKT type of formulas. You may have to use like Holiday 2 or many of the ones which are available online, like the Kane formula. Then you have to keep the IOL ready because your normal inventory, you may not have powers like plus 30, 34 or beyond that. And most of the companies make only up to 34 diopters. So beyond that, you may have to think of piggyback IOLs. There is a possibility of the intraocular pressure elevating during the surgery also. So all of these patients, invariably, I always start IV mannitol unless there is any medical contraindication for that. In some cases, you may need to give a block also with a good massage. And one important point is we have to just dilate the patient just before you are doing the surgery. Like if you have a big list, it should not dilate the patient right in the morning and do it as the last case. Interop challenges, anyway, I'll be talking along with the videos while I show the videos. So this is a normal cataract with a shallow AC. So this patient was moving the eyes a lot, so I thought I would go in and do a subtenance block because you don't want to have handle two problems at the same time. Because while you are operating on a shallow AC and the patient looking all over the OT, it's not very inducive. So when you are injecting something in the AC, you find the subincisional iris jumping. So that itself is an indication that in this case, that the AC is quite shallow. And the rexis also is a problem. You cannot do a normal rexis like a shear. As you can see, I am doing the rip maneuver because the anterior capsule is convex. So there is a chance of this rexis escaping. And the biggest problem is when you try to insert the probe. As you can see, our aim is to protect the cornea. So we always try to go along the wound and then the iris gets aspirated or stuck into the phaco probe. The point is you have to use only irrigation while you are going in. And you have to sometimes need to use high density viscoelastic also over the subincisional iris. After that, of course, the surgery is quite uneventful. So this is again a typical case of post-angle closure glaucoma cataract. You can see the iris atrophy. There were two large iridotomies also. So in this case, the problem is that one is, besides the shallow AC, one is that the pupil is going to be very rigid and it will not dilate beyond the particular point. And there might always be, you should look for any small subluxations, small to large subluxations, which is also possible in a post-angle closure glaucoma attack. So this is one of the cases which I had operated. A similar case I had put in a CTR also. So the rexis was slightly small. It was around 4 millimeter, and this is how the eye came after a couple of months. Totally capsular phimosis, and it was not cutting with YAG also. So I had to again go in and cut it with a Vanas. Many of these eyes, they also have the problem of a deep socket. Because like I told you, the eyes are small. So normally myopes, you find them will have prominent eyes, whereas those hypermetropes and all, they may have deep set eyes. So there is additional problem of, you can see the fluid, it's all getting collected in the fornix, in the conjunctival sac, and that will reduce the visibility. Your depth perception gets hampered and there is a chance that you can cause a posterior capsular end, because you may think you are away from the PC, but actually, in fact, you may be quite close to it. So that is one thing. Another thing is, of course, the IOL that I was telling you. So in this case, I had to use the plus 34 diopter, so which fortunately was available with the manufacturer, and so that lens could be placed. But anything beyond that, of course, you will need to put a piggyback lens. This is one case which really stretched my patience. So it was like a hard cataract, and while doing the hydrodissection, the nucleus normally lifts. No, after that the eye became hard. What we call as intraoperative hard eye. You can see the iris coming out through the main wound. The wound was quite okay, but still the iris keeps coming out. That is because of the rise in the intraocular pressure. So trying to replace back the iris, again you have to keep checking the intraocular pressure with the dome of your cannula. Always better to reposit from the side port with a cyclodialysis spatula. And then once more trying to get in the phaco probe, but even before I could start doing it, the iris comes in. In this case, I had already given IV mannitol, so I cannot repeat it again. Burping out some of the visco, because sometimes overfilling also can lead to a hard eye. Again it keeps coming. Then this is when I inject some amount of viscoat over the subincisional iris, trying to make some space. And now I am finally able to get in the probe, but then still the iris keeps coming and coming into the port of the phaco probe. I tried to disentangle it with my chopper, but then I thought it's better to come out now. And then that's when I thought I should do a vitreous tap here. So you mark the pars plana 4 millimeter, then with a 26 gauge needle, I go in and just aspirate 0.01 to 0.02 ml. That much is sufficient, and you have to immediately close it with a bud. And then after that, you can see the AC is formed very well, and the rest of the surgery goes in. After that, the surgery is quite smooth. Sometimes they do say that you should not do a tap, that there is a possibility that you may have vitreous incarceration. But what I have seen is that if you have to go in with a vitrectomy probe, you need at least 23 to 25 gauge. Many of the time, those sort of small gauge vitrectors are not available with the routine phaco machines. So the ones which are available are either 21 gauge, and when you try to push in such a large vitrector through a pars plana, you may end up causing more damage. So I always prefer to do a vitreous tap with a needle. But what is important is that at the end of the surgery or the next day, you have to do an indirect ophthalmoscopy. And after 2 weeks, a regular indirect ophthalmoscopy with scleral depression. So at the end of the surgery, though we have struggled so much, only the little bit of iris stretching which is there in the subincisional area, otherwise it looks okay. Then another scenario where you get shallow AC or hypomature intumescent cataracts. So here the challenge is doing the capsular excess, because the lens is, as we know, is quite intumescent. So I am using a dispersive viscoelastic to flatten the anterior capsule, and stained also. But there is some fibrous plaques also on the anterior capsule. So those areas excess is difficult. So we have to go around those plaques, while including the plaques within the area of the removed capsule. And still in one area, the rexus is still attached. So you just trimmed that part also. And then after that, you can, once you have decompressed the lens, you have removed all the liquid cortical matter. After that, you can safely enlarge while using a microforceps. After this, the surgery is not that much difficult, because it's like a regular white cataract. So it will go off as, then the end of the surgery again, and the other side also, because the rexus is small, I had to enlarge once more. Then some cases, I think you should be prudent not to do phaco, because you cannot do phaco in all cases. So this case, preoperatively, it's a hypermature intumescent cataract again, but I thought that the AC was slightly irregular temporally. So because of that, I went in, I did a scleral tunnel. So after staining, when I was washing the Trypan blue, I saw a blob of vitreous in the wound. So there was a subluxation temporarily. So I did a vitrectomy initial, because already vitreous is there. So did some vitrectomy. clearing whatever vitreous has come into the anterior chamber. And then I thought it's better not to go with a rexus and then go do a phaco. That will be like too much of manipulations and risk. So I thought I'll go in, enlarge the tunnel, and I thought I did a intracapsular cataract extraction. So this is something we used to do initially during my PG days. I have done with a cryoprobe. So this is something like that. So what is important is that you don't rupture the bag at this point, because if the bag is ruptures, all that fluid cortical matter will go into the vitreous and it can cause severe inflammation post-op. So managed to remove it intact, and vitreous is obviously there, so some amount of vitrectomy. Another thing I want to highlight here is that one should not use irrigation while removing the nucleus. So I am going in with and putting a iris claw lens, as we just saw in the previous session. And this iris claw, the advantage is you can put it in any axis. It need not be horizontal like the other lenses. You can put vertical, oblique. So this particular forceps is the one which is available and quite, because it has got that particular shape, flat edges. So it's useful to hold the lens. So you get a good result at the end of it. So thank you. I have tried to cover some of the scenarios where you normally get a shallow anterior chamber. Thank you.
Thank you, sir, for that great talk, because it is actually a very difficult situation where to do a phacoemulsification in very shallow. So as sir told, with a well planned, we can also do a phaco properly in a patient with shallow AC.